Okay. I think I told about posterior condylar offset like this. So I told about the importance of PCO. So an increasing PCO is associated with the increase postoperative fractions. And today, uh, can you see my presentation? Okay, right?
Yeah.
Okay.
Yes.
Have it changed? Change new presentation?
No. No.
No?
Yes.
Same?
No change. No. Change. Change. Yes.
Change? Change?
Yes.
Okay.
Okay.
CRD.
Okay.
Okay.
Yes.
Okay, but unfortunately, in the CRD, it is a disadvantage regarding the after the fraction, after the post-operative fraction. It is a little bit limited regarding the post-operative fraction of the CRD. Why? The reason is the fraction gaps tend to be tight due to decrease the posterior slope. And in the most patients, the native or okay, someone coming. You Chanta. In the most patient has the pre-operative steeper posterior slope, especially in the Asian countries. Yeah, so after because the posterior slope is fixed up to 9 degrees. So normally 5 degrees or 3 degrees. But it tend to be less steep after the operation. Then the posterior fraction gap can be tight after the operation. On the PCL contracture, the PCL is always contracted because in the flexion, PCL can be tight. That's why the posterior movement of femur, so-called rollback motion, can be introduced. But in contrast, in the later ORG, PCL can be shrinked, can be tight due to the contracture. So it is another reason of the tight flexion gap. So how to resolve this? One is that make the greater posterior slopes. In the molar kinematical alignment knee, the posterior slope will be followed as the original posterior slope. So, but it is sometimes too steep in Asian and Japanese patients. It is some patients have more than 10 degrees. So 20 degrees, 12 degrees, and even 15 degrees in some cases. If we cut to steep posterior slope, so there is some problem that the steeper posterior slope can cause the PCL damage. And because the PCL is inserted to the posterior cortex of the tibia, approximately 2 centimeters. So if we cut the deeper and deeper, and the most part of PCL can be damaged or detached. So to maintain the posterior attachment to the posterior cortex to the tibia, so some surgeons prefer to retain the bony island to cut the bone, retain the bone around the PCL insertion, just like the bony island. But it is sometimes this bony island can break and lift up, and eventually PCL insufficiency can occur. So I don't like to make the bony island. Instead, I detach the PCL around half or 1 centimeter below the joint line to to protect the PCL damage. So after that, I insert the PCL retractor and push the tibia anteriorly. Then the PCL can put backward behind the PCL retractor. But even to this maneuver, PCL can be damaged. So steeper posterior slope is very, very risky regarding to the PCL retaining. In addition, after the P2 steep PCL, the tibia can push anteriorly due to the steep PCL. So this is the vertical cut. This is the posterior side, and this is the anterior side. If you cut the two steep posterior, the femur bone come like this, and then after the load bearing, the tibia can push anteriorly due to this steep slope. So we should avoid the too steep posterior slope. Maybe I believe this must be up to 7 degrees. 7 degrees should be the maximum. So another measure is about up to 7 degrees and the smaller size selection. So we always use the sizer. This is the anterior reference one. Maybe I must say before. So anterior reference sizer means so anterior cutting surface is decided, and the size variation can be adjusted to the cutting thickness of the posterior condyle. So if we select the smaller size, if the indicator indicates, the sizer indicates between the two sizes, for the CR knee, we always select the smaller one. Even on one size down to enlarge flexion gap. So just like this. So smaller posterior condyle, the too much posterior condylar cut can cause flexion gap, the expanding. So we can get the wider flexion gap. But this can also cause the small PCO. The small PCO means posterior condylar offset. So as I said the previous presentation, the smaller posterior condylar offset can cause a limited postoperative flexion angle. So we need to retain the posterior condylar offset. In the same time, we should keep the larger flexion gap. So this is very difficult to get the larger motion. In addition, in the CR knee, we sometimes experience the paradoxical motion. That means in the initial phase, the flexion phase, the contact point move anteriorly. In other words, in the early flexion, the femur slide anteriorly, then roll back. So the normal G, the most PS knee is contact point move posteriorly continuously. So during this paradoxical motion and until the translation, the patient will feel this instability and discomfort that can cause the dissatisfaction after the TKA. So then, this is the normal situation with the intact ACL. After the cut of the ACL, because most ACL TKA need to cut the ACL, that can cause anterior translation. In addition, most CR knee have the posterior slope that also can cause anterior translation of the tibia. So in the flow extension, the contact point comes here, not here. But just after the reflection, for example, in the mainly 20 or 30 degrees, this anterior translation, in other words, anterior subluxation of the tibia can reduce suddenly, then a continuous rollback with around 30 degree to 90 degree or 30 to 60 degree. So this is the anterior movement phase and then go back. So this is another cause of the limited motion. And in the sometimes rollback is insufficient even after the reduction of this early phase of anterior translation. Then this is the report of kinematics. This is the normal kinematics. This graph shows the contact point. This is the knee flexion angle. So this is the rollback motion. And in the normal knee, the rollback motion should be 3.4 millimeter in the medial side and around 2 centimeter in the lateral side. This is a normal rollback motion. This is almost a continuous posterior movement. This is a normal posterior translation or posterior rollback motion. But this is a PS knee. PS knee as translation, posterior translation is a little bit smaller, just 3.7 millimeter, around 1/4 of the normal knee. And medial side is only 1 millimeter. So, but it is still continuous. So the medial side is very stabilized, but lateral side is gradually moved to the posteriorly. So it is a smaller amount, but the normal posterior movement, because this motion is induced by the post and come mechanism. In other words, this is a guided motion by the engaging mechanism. On the contrary, this is a CR knee. CR knee is we can see the paradoxical motion in the medial side. The contact point is the millimeter, the degree is here, and then move forward suddenly, and then go back. So this time the patient has a discomfort. So again, this is the same. This graph shows the contact points change in several patients. And CR knee, in summary, CR design experiences a greater flexibility on anterior translation and less posterior femoral rollback than PS design during the weight bearing and the deep flexion knee bend. In the other, please have a look. This the crucial retaining this CR knee in the contact point is anterior compared to the PS knee. So in addition, the translation is the CR anterior translation is positive, and in contrast, the PS knee is negative anterior translation. That means the posterior shift, posterior rollback. And lateral is as well. So CR is very small amount of rollback motion in even the lateral side. In contrast, the PS knee can move greatly compared to the CR knee. This is the difference. So I'd like to show you the meta-analysis regarding the postoperative flexion comparing the CO and the PS knee. This is the previous meta-analysis. these are several studies, and most studies show that after the PS is CR is less frequent. Less flex. Flex is the better in the PS. This is the worst in CR. This one. In summary, is the PS are more likely to get more deeper flexion compared to the CR knee. Of course, but some studies show that the CR was better than the PS, but most studies show that PS is better. This result is around 4 degrees is better postoperative flexion in PS knee than CR knee. There are several other meta-analyses comparing the PS and the CR postoperatively. In summary, the difference of postoperative flexion angle is around 3 to 5 degrees. In summary, around 3 to 5 degrees more flexion the PS can get. So there are so many meta-analysis studies, and this is the multi-center prospective study to comparing the CR and the PSE. This is the absolute flexion angle after the TKA. I don't remember, but it was around 1 or 2 years postoperatively. The flexion angle is better, significantly better in PS knee. And ROM improvement of ROM is 2 times higher in the PS knee. But both angle had significantly difference between the CR and the PS. So this is another study of the passive flex, the comparing the PS and the CR. But this is PS is high friction design. I will explain later. This is also significant difference. But many studies show that only the friction angle was different between the CR and the PS knee. In other score, for example, pain score and function score such as KSS and Oxford knee score was equivalent between the two types of components. So the difference was just friction angle. So as I said before, many components have the high friction design. So what is the high friction design? This is induce the more deeper, larger posterior translation due to the post and come mechanism. This one difference is this one. This wedge is larger in high friction design compared to the normal design. In addition, contact point is lower compared to the standard design. That means the torque to act on the tibia tray is the greater in this one due to the Levermer effect. The lower contact point can reduce the stress on the bone and tibial component interface. In addition to thickness of posterior condyle is thicker in the high friction design. So that means that we can control the contact area even in the deeper friction because the thin posterior condyle can cause the point loading, edge loading during the deflection that can cause the polyethylene wear or significant stress on the bone and the tibia component interface. So we can control the contact points and the thicker posterior condyle and rounded. This is the round shape. This is a little bit sharp shape on the rounded shape, and slightly lift up posterior condyle, posterior polyethylene. So that can cause induce a posterior movement and a larger contact point. So this is a comparison between the high flex design and this is a standard design. The contact point is comes to anterior and very, very limited area. It implies the point loading is occurring in this situation. But on the contrary, this is a high flex design that can keep the wide contact area and the contact stress is reduced compared to the standard design. So is it effective for high deeper flexion? There are two meta-analyses. The one meta-analysis showed that the high flexion PS achieved the deeper flexion angle compared to the standard PS and PRV. But another meta-analysis, the postoperative flexion angle was equivalent in both components, both high flex PS and standard PS. This is a retrospective study shows that high flex PS and high flex CR and the standard CR, there was no difference among these three implants. But so some surgeon is worried about the early possibility of the early failure. Of course, this high flex design was designed for the high flexion, but such high flexion activity can cause significant mechanical stress in both tibia and femur components that can cause early failure. So, but there is no report regarding the high flex design and relationship with the early failure. But in summary, the effectiveness of high flex design to the achieved high flexion is still controversial, and even we should carefully observe that it can cause the early failure or not. But high flex design might be safer, mechanically safer, because we can get the deeper, wider contact area between the femur component and polyethylene. So, in fact, we need to look more after. But it is very difficult because some components can cause in the high friction and the reduced posterior thickness of the standard design. So in the same bone cut. So we can select the high friction design and the standard design depend on the friction gap. So for the person, for example, next gen have the thinner side in the same bone cut. So it implies if we cut the bone after the trial, the friction gap is too tight, we can select the thinner posterior condyle thickness. So we can adjust the gap according to the component thickness. The next gen had such the variation of the component, but current persona doesn't have. So another solution to get the deeper friction is the medial pivot. Medial pivot means the medial sides are stable around 1 or 2 millimeters during throughout the motion, and lateral side should go back greatly around approximately 2 centimeters. So this study compared the two type of knees. They measure the medial pivot if the knee has a medial pivot or not. They selected the 20 cases with the medial pivot, and another 20 cases no medial pivot. They use the same component in the same operation procedure, and then they measure the medial pivot interoperatively, then compare the post-operative friction. Before the operation, the friction angle was equivalent, no change. But post-operatively, without a medial pivot motion, friction angle was limited, significantly limited than the medial pivot one. So this study showed that the medial pivot will act as a positive factor for deeper post-operative friction angle. So this is the mechanism of medial pivot knee. Medial side, this is medial side is the high constraint, high conformity for just like the TKA. Just like TKA is bone and socket configuration articulation. In contrast, lateral side is flat on curve. So this can move lateral condyle of femur, can move anterior and posterior freely to around the medial side. This is the persona. Persona also has the medial pivot knee. This is the medial configuration conformity is very high. On the other hand, lateral side is relatively flat. So this articulation, the shape of polyethylene can induce the posterior movement, posterior rollback of the lateral side. The medial side is stabilized due to the high conform of shape of the polyethylene and the femur component each other. So this is a contact point. The vertebral area is the contact point. This medial side is the 0.45 degree. The contact point is very wide, and after that, the component, femur component can roll back. This is a UC knee. I come to talk about the UC knee. This is a high conform type, both medial and the lateral side. This is the PCL sacrifice component. The stability is provided by the shape of the polyethylene. That means a high conformity both medial and lateral side. That can cause the anterior and both anterior and posterior translation due to the capture of the convex shape of the polyethylene. So in this component, rollback it never occur, and the contact point is very, very stable and in the same time. So it is maybe this can be disadvantage for regarding the deeper postoperative friction. So this is another medial pivot knee. This is a metacular knee, and this is a microport knee. This knee and medial side is a complete cup and socket shape. So medial side is a complete sphere. So polyethylene has the concave shape. The shape is completely matched to each other, just like THA and Oxford knee, and lateral sided flat. These knees need to cut PCL. So instead of PCL, this high conformed medial side can give the stability of the anterior and the posterior side. So the last topic to get the high flexion is, it is still controversial. So loose flexion gap is the positive effect or negative effect. So roughly saying, the CRV, it can act as a positive effect. So one study showed that in the posterior cruciate retaining TKA, CR TKA, large flexion gap, the extension gap provides better postoperative knee flexion angle compared to the equal flexion and the extension gap. That means the surgeon should make the slightly larger flexion gap compared to the extension gap. So how to achieve this? The one is to get to the steeper posterior slope or select the smaller size, the female component. That can act as a positive vector. But again, if we choose the smaller component, PCO, posterior condylar offset can be shortened. That can act a negative effect regarding to the flexion, deeper flexion. So PS, regarding the PS knee, it is still controversial. There is mainly the most reports show that in the PS knee, loose flexion gap act as a negative effect to get the deeper flexion gap. So difference between the flexion and extension gap was negatively correlated with postoperative knee flexion angle in J-shape design. That means the single radius design, the posterior stabilizer TKA. I don't know the reason, but sometimes maybe the stability in the PS knee can be provided by the common post and com engagement. So, but loose flexion gap can cause abnormal engagement of post and com. Maybe I think this can be the reason of the negative effect of the loose flexion gap on the PSE. So, but one study compared to the patient who can get to, let's say, the sitting after the TKA operation, and this is the control of impossible postoperative instead of sitting. So they compare the intraoperative gap in the individual angles. So the small, the patient can get to say the sitting like this, have the greater flexion gap compared to the patient that couldn't sit like this. So they say the greater flexion gap can act as a positive effect to the PS knee, to get the flexion angle even in the PS knee. So it is still controversial. So another the hint to get the deep flexion angle. The one fact is that every knee can flex fully intraoperatively. I haven't seen the knee, the knee can't get the full flexion intraoperatively. Because why? After the operation, the patient can flex the knee fully, but intraoperatively they can flex the knee fully. What is different? Because I think postoperative pain and swelling can restrict the deflection. This is one hypothesis, or some way of the rehabilitation. But it is quite difficult. So aggressive rehabilitation can cause the more severe pain that can prevent the deeper flexion. So I don't know the best way to the rehabilitation. And how to reduce the pain and swelling. It is another solution to get the deflection. If we can control completely postoperative pain and swelling, the patient can get more satisfied deep flexion after the operation. But I don't know how to get them. And posture of the wound closure. And the classic, in the classically, the knee flexion angle during the suture can influence the postoperative flexion angle. So the study recommend to have the suture in the deeper flexion angle. But sometimes if we have the suture in the deep flexion position, after the extent, the wound can open because it can, in the extension, everything is looser. So yes, different concept knee. So I explained about the medial pivot knee and ACL retention. Currently, bicruciate retained knee is the focused on. It can sometimes it can act very good postoperative ROM. So kinematic around knee. So current bone concept is mechanical alignment. It is perpendicular to the mechanical axis, but it is not anatomical. In anatomically, the joint line is not perpendicular to the mechanical axis, is a slightly varus alignment. So this difference can cause a limitation of the ROM. So, of course, so if the patient can fulfill the indication of the UK, if you do the UK, the patient can get the deeper flexion. So the UK is the best solution for the patient. They can the suitable patient for the UK. Okay, this is the end of my talk. Thank you for coming. Please see you tomorrow. Oh, sorry, okay. If you have any question or comment, send me my email or some comments. Okay, see you tomorrow. Bye.
Thank you, Professor.
See you tomorrow, sir.
See you tomorrow. Hi.
See you tomorrow, sir.
See you tomorrow.
See you tomorrow, sir.